Hello, it's Dr. Shelly. We're back. You just had a quiz. And if you don't know anything about the quiz, you better go back because this video right here, these are going to be the answers to that quiz. Like I'm about to tell you what the answers to the quiz was. You don't want to see the answers to the quiz, better go find the quiz. All right, now, so let's go. What are we doing? What is Shelly doing now? Shelly, through HETV, Shelly's Nursery Review, is giving you the Oh My God Packet Quickie, page 6, part 2, on who not to prioritize on your NGN NCLEX. And just in case you forgot, we started this on, again, page 6 in the Oh My God Packet. We started this on page 6 with the NCLEX Quickie, and this was who you see first. We did it last week. And now who you should not see first. Hope I'm making myself clear. Like, this is getting old. All right, so here we go. You were told to put these in order. Your girl is going to give you the answers, but then I'm going to explain why I chose those answers when I'm done. Okay, so you ready? Here we go. You took report on 6 patients at 7-ish in the morning. Now you have to prioritize those 6 patients. Like, what are you going to do for them? Which patient you're going to see first, second, third, fourth, and fifth, and sixth. And so that's what we're doing right now. Now, just to recap, you had to administer 730 insulin after the blood sugar was obtained. You had to do rounds on all 6 patients. You had a patient complaining of left calf pain that was severe, and they were scheduled for a venous Doppler ultrasound. You had a patient crying with their brand new diagnosis of cancer that they just received. You had somebody else angry because they had been waiting for over an hour to get discharged. You had to prepare and pass your 8 o'clock meds in the middle of all this shit. And frankly, this is my life. This is realistic. So what should we do or see first? Well, let me tell y'all about my 40 years in the biz. You better go make rounds on all 6 patients first. That is always your priority. And in case you don't know what the hell I'm talking about, let me tell you how it's gonna go. Once I get report on 6 patients, when I work on that one unit where I do nursing stuff, when I get report on those patients, because remember you guys, I stayed PRN at that tele unit that I work on. In fact, I'm working there on July 4th, just one day a month I work there. So when I go and I get report on July 4th on all 6 of my patients, because 6 patients is pretty typical, and if I'm lucky I'll get 5 or 4, and then I'll be like multi-orgasmic, because what the fuck, I can't believe that. But if I get all 6 like I'm usually gonna get, which is fucking every nurse in America, because it's really hard to do 6, but that's what we all know we gotta do. When I get report, I am gonna literally stop the presses and go around in each one of them rooms for 2 seconds like this. Watch this, you ready? Okay, you ready? Y'all watching me? Hey, Miss Martin, how you doing, girl? I'm gonna be your nurse. Now, I can't stay, I'll be back. I'll hit you up in a minute. Hey, Mr. Willis, I'm going to be your nurse today. My name is Shelly. I'll be back, okay? I got to check up on other patients. Hey! Now, I'm checking in every single freaking room just to make sure the motherfuckers is alive. What did I tell y'all? I have seen it where the aide, the nursing assistant, the nurse, everybody documenting about the patient. Patient been dead for hours. Because they little trifling ass ain't even went in the room to make sure the patient is okay. I think all of us know people like that. So no, this is first. Make rounds on all 6 patients first. That does not take you long. You ain't in there to change a dressing. Oh, hell no. You ain't in there to do nothing but see if they're alive. So what things have I found when I went around to do my rounds? I went in one room. Central line dressing was removed. The patient was off the chain. They had Alzheimer's. They was having a moment. They ripped that shit up off their central line. Thank you, Jesus, the central line was still intact. But I don't want to find this shit out 2 hours later. That's just one. Let's do another one, shall we? Go in another room, and the NG tube feeding that's supposed to be feeding a patient is feeding the floor. The shit is all over the floor. And you know how sticky and nasty NG tube feeding is. It's feeding the floor. I go in another room, and brother man, for whatever reason, wants to climb right out of the bed and get his legs stuck. So he didn't even fall. but he's stuck. Crazy. Okay, so do what I told you. Go in every room, make sure everybody alive. Before that nurse that you about to get report on, before they give you report and take their asses home, another good way to do this is to do the report in the room. Some of y'all, I don't know what you think this is. Like if you think maybe you signed up for dietary, or perhaps you're working in environmental services, or maybe you think you're just, I don't know, home designer. I don't know, but this is medicine. This is where people die. So if I know that the nurse before me was responsible for 12 whole hours for these patients, and I just came in, me and that nurse who should know that patient real well is gonna go in each room so that if anything is going crazy, I'm gonna let her know. Now, one of the things that I'm gonna give you for free, I said for free, you ain't gotta pay for this shit, shit is free, is the best thing you can do, because I've heard your complaints, I've seen your messages, I've seen all of you and talked to most of you who said, what do you do when the nurse gets report and the patient is all jacked up, or you come in and you know there's so many things that the doctor ordered and they were never done. Oh, I got you. That's one of the reasons why you make rounds on all your patients. Because when I walk in the room and I'm getting a report, and I know because I get there before the nick of time, because some of y'all run in, you know, you got to start at 7, you run in at 6:59, 59 seconds. That's stupid. I come in around 6:30 for my 7 o'clock shift. I spend a half hour reviewing all kind of crazy stuff on every single patient, including my orders. I see who ain't got labs and who do, and the ones who ain't got labs, I don't want report on. There's a nice way to do it. You don't be like, you know, acting like an ass, but you got to do it nice. So how do you handle that? Because I know you want to know. This is how I handle it. Oh, I see you've been the nurse for room 7, and I'm taking over on room 7. I know you want to give me a report on room 7 and 8 and 9. So I'm going to take report on 8 and 9, but can you do me a favor? Before I take report on room 7, can you get those labs? Like she was ordered a CBC, a CMP at 9 o'clock last night. It's 7 o'clock this morning, so I need you to do that before I take report. What did I just do? I let her know I'm not stupid. You're going to do that before you give me report, because what's the law? The law is once I take report, I'm responsible. And now when the docs roll up and the nurse practitioner roll up like me, when we roll up, like I'm a provider, remember that. When we roll up and we see you ain't did the labs we ordered, oh, you can shoot a new ass. We don't give a fuck about the last shift. You got the patient now, and you was supposed to make sure that shit got done the minute you hit that flow at 7 o'clock. Okay. Next, y'all rolling with me? Y'all good? Okay. Let's do number 2. Number 2 is administer 730 insulin after blood sugar is obtained. I think all of you know that, but let's put it in perspective, shall we? When you think of giving insulin, it means your patients are diabetic, and it's pretty fucking serious, because when you look at your full day, it's that diabetic that's gonna fuck it up. It says after the blood sugar. That's important because you can't give insulin without a blood sugar on the chart. In fact, if the blood sugar is on the chart and you are more than 30 minutes late giving insulin, now your day is kind of fucked up because you got to get another blood sugar. And your aide don't really want to hear that shit because she all the way down the hall on her other blood sugars. So you need to understand how important it is to give insulin within 30 minutes of a blood sugar. And you need to understand that the diabetic patient is a high priority in terms of you making sure that that blood sugar sister girl obtained, your nursing assistant got, isn't low. Y'all remember that? Y'all remember that a low blood sugar will kill the patient before a high blood sugar? I'm not worried about no 200s, 300s, 400s, or 5. I'm worried about that 40, 50, 60. That's what's going to kill your patient. Remember I said that, y'all. That's always on the test. Number 3. Patient complains of severe left calf pain, scheduled for a venous Doppler ultrasound. Now, I want to say this on the outset. When they're scheduled for a test, they're really not your priority. But you and I both know that a DVT, can turn into a PE. So every deep vein thrombosis, or keep it on the low, clot in this man's calf, right? Because we got to break it on down for the patient, right? So we talk DVT with us, deep vein thrombosis. Sometimes we go higher level. We say VTE, venous thrombotic embolism. Girl, fancy. Or we say simply to the patient, because you got to break it on down, there might be a clot in your leg. Okay? Now, why are we going in there as the third person? Well, it has to do a lot with the fact that the patient with a clot in their leg, that clot could break and travel all the way up the leg to the lung. If it travels to the lung, you and I know that's a pulmonary embolism, which kills 80% of people. Not fun. So every PE started out as a DVT, which is why you took your hind parts in that room to make sure that patient is cool. Now, I got to tell you, if there was some other stuff down here that I could put down here, this would not be a priority. And one of the reasons why this would not be first is because they were already seen if they were scheduled for a venous Doppler ultrasound. Who orders a venous Doppler ultrasound? The doctor or nurse practitioner. So if that was already ordered, they've been already seen. This whole issue about being your urgent patient may be seen first. It's not going to happen because you got these other two nightmares to deal with. So this one is actually third, but it's not a very high priority in the grand scheme of things, except for you know your pathophysiology, and you know that a clot in the leg can break off and become a clot in the lung, and that is deadly. Hope I made myself clear. The fourth person that we're going to see is way down here, and it's not a person so much as it's a task, past the 8 o'clock a.m. meds. Because these two, they have some issues, but you're going to see one of them when you give them their meds anyway. So like, get the meds done, okay? Because you should take seriously your discharge teaching, and you should take seriously the patient crying, but not as serious as you do the fact that patients with high blood pressure, yeah, they need those meds, and they need those meds now, because some people are so reliant on their metoprolol, which is a beta blocker, or their lisinopril, which is an ACE inhibitor, or their cardizem, which is a calcium channel blocker. I mean, they can just click right into high blood pressure. Your patient with the calcium channel blocker can turn into AFib. When I walk in, oftentimes in the morning, I'll see, oh, look at that blood pressure. Because what did I do? I reviewed them vital signs, right? I didn't come at the nick of time at 7. I came at 6:30. And I looked at the vital signs. It was like, oh, wow, that's high. So you feeling me on this? Get in there and just get the meds, okay? Boom. Now, you have 2 patients left. And we're going to look at both. One is the patient is angry because they have been waiting over an hour for discharge. I think you know this. Discharges are last on our list. We don't give a fuck about discharges, because here's what it means. If the nurse practitioner or the doctor discharged the patient, they must be doing pretty good. So there's no real crisis in your mind. And if they're angry, we don't give a fuck, right? Nobody give a fuck about your anger. Now, don't get it twisted. Anger does not control what I do. Patients' lives and their health does. So some of y'all get kind of worked. I'm saying this for a reason, because some of y'all get worked up into a sweat, and you start to get tachycardic, and you get bubble guts because you heard the patient was angry. I don't give a fuck. I ain't scared of shit. You shouldn't be scared of shit. There's a way to handle anger, okay? Let me show you how to do it. Now, when you walk in this room, bruh, man want to cuss you out. I've been waiting all day. 2 things need to happen. First of all, if you are blessed enough to catch the doctor or the nurse practitioner in the room with the patient at the time, and they say, and let me quote them because I've been doing this too long. They say things like, okay, Miss Martin, we're going to be able to discharge you today. I want you to follow up with me in the office. I also ordered some physical therapy. There's a new med list now. Some of those meds you were on are a little bit outdated. So Shelly here is going to get you together with all that. Shelly, yo girl, here's how this is going to go. After the doctor or nurse practitioner says all this shit, nurse practitioners don't even talk like that because they already know what the fuck it is. They was a nurse first. Me. So if it's a doctor who says that, say, whoa, hold up. Okay, Dr. So-and-so, let's be real with the patient. You are discharging her today, but it's 8 o'clock right now. Technically, by the time you're done with all your paperwork and you're rounding with the other doctors and I'm done with mine, they're talking about 2 o'clock p.m., aren't they, doctor? Oh, yeah, that's right. Shell's right. Shell Bell's right. She knows because, you know, we have a lot of things we have to do to make this work for you to go home safely, including pharmacy and all the rest have to come in and lock in and approve the meds. And yeah, Shell Bell's right. It's probably going to be about 2:30 before you get out of here, okay? Is that cool with you? Because if you let this doctor get away with this, and they don't know no better, they good people, they just don't know, and the doctor walks out the room and now you're the only scapegoat. 8:30, bitch, where you at? Where my discharge paperwork? What the fuck? My wife, it's my favorite. My wife is waiting for me at the Circle Drive. I got to go. She been here for an hour. And it's a real concern because the patient doesn't know any better. And the wife is trying to be on time for her man. She driving around the Circle Drive. And you got to remember what happens at the Circle Drive. At most hospitals, police tell about, you can't stay here. You got to go. Come back around. Maybe your husband will be ready. Then you become a bitch. Yeah, it's not cute. So again, there's a way to handle this. I gave you the way with the doctor. Let's do the way with the patient. Some patients are really angry. Like they used to like, especially at the clinic, they used to like money talk bullshit. Well, where the fuck you at? Okay. Cause we got big shots, right? For the most part, we got a lot of big shots. I mean, they are pretty wealthy. They're CEOs, they're CFOs, they're presidents of this and leaders of that. And it's like, ooh, intimidating. So you walk in a room and you're like, hi, I'm Shelly. I'm going to be a nurse. Well, I hope you're ready to discharge me because the doctor discharged me this morning. Oh, okay. Well, I'm excited for you. That is really good. You must be doing really well. And yes, I'm going to facilitate everything I can to make this day a discharge like real fast. However, let me ask you something. When the doctor walked in with the discharge, did he mention whether or not he had completed all the paperwork? Oh, I don't know. All right, well, can I go check on that? I'll be right back for you just to see if he put the order in. How many of us know this doctor ain't put that order in? This motherfucking order ain't coming till 11 o'clock. So one thing you do when you say, let's go see if the doctor put the order in, is you make it plain. I ain't got no fucking power to let you up out of jail. Oh no, I need a discharge. Okay, so I come back. Okay, got bad news and good news. You are discharged today, but there's no order to do it. I let him know that so that he's on top of the fact that you want to go. Now, an hour later, no discharge has been written. He's calling you to cuss you to clean the fuck out. You walk in the room. Now he know you. Shelly, I thought you said I'd be gone. Like I thought this order was supposed to. Okay, I need you to understand that I don't have that kind of power, baby. But I am going to put another note. Matter of fact, I'm going to let you see the note. I move that wile right over there by his eyes. Let him see the note that I'm typing the doctor. Patient getting upset, really wants to know how long it's going to be before they can be discharged. So you can do it like that just to show that you're manipulating and doing everything you can to make this go. Or you can frankly say, you know, Mr. whatever, fill in the blank, asshole. Yeah, your discharge is being written, but you need to understand that just like when you came in and I admitted you 2 days ago and you were really sick, that's happening right now with that doctor and another patient. And so your discharge order is not the highest priority right now. If someone's life needs to be saved like yours when you came in at Thursday. Remember when I, admitted you Thursday at 8 o'clock and you couldn't breathe? Yeah, I need you to just be a little bit patient with us. Can you? Is that all right? All right, now let's go look at the last patient. It may sound really mean, but you made her last. Last patient. Patient crying and upset with their new cancer diagnosis she just received. It may sound like you should have gotten in there first. No, it's not that you're a heartless provider. No, you love patients. But if you go in that room before you do some of this other stuff that we said was the highest priority, if you go in that room, everybody on the list is going to take a back seat because dealing with a patient who just found out they have cancer, they require a hug. They require you to hold their hand. They require you to sit your ass down and listen. They require you to be empathetic and compassionate and loving. And it requires time. You're just not going to walk in and walk out. It's not going to happen. So if you got all these other tasks done, including Mr. Asshole, who wants to be discharged yesterday, then you have more time with the patient who has just had their whole life changed before them. So I hope this helped. Now, when I come back, we're going to do who not to see first in great detail and show you how that applied to the list. Bye, Felicia. Deuces.